about a case of non-ischemic cardiomyopathy having a VT storm. Please mute all audio. Our case is 59 years old African male with known hypertension and diabetes presented to us with VT storm. His history started 3 months ago by recurrent palpitation and syncope. Palpitation was documented to be a Y complex tachycardia, for which he received a recurrent DC shock to terminate such tachycardia. His ECG, as you can see, it is a Y complex tachycardia, and it's probably VT. It's had odd axis. AVR is positive, and lead 3 is positive. So its axis about right axis with 170 degree, and it is of apical origin as V3 and V4 almost have a negative complex. This is suggestive of an apical origin of VT, mostly originating from the apical lateral wall. So this is also another documented VT for the same patient. As we can see, it is different morphology from the previous one. It has a left superior axis, lead 2 and the 3 and the AVF are negative. So the axis is about -80. And also, again, V3 and V4 is an negative Chiari complex, so suggestive of apical origin. So also this patient have an apical VT arising from the inferior wall. So at least we have 2 different exit of tachycardia or 2 tachycardia isthmus, both sharing apical origin, one from the lateral wall and one from the inferior wall. So also he did an Holter recording. As we can see in the Holter, a multiple different VT. This one, which had a positive in ECG1, biphasic in ECG2, which is like that and like that, while this is completely negative concordance, which is a different VT. So the different VT is also recorded on his Holter monitoring. About his echocardiography, first thing when we see a Y complex tachycardia, we ask for echocardiography. His echocardiography show concentric LVH. It's about 15 millimeter with fair LV systolic function about 50 to 55, but no apparent resting segmental motion. And of course, coronary angiography was done, and it was within normal with no significant coronary disease. So our case is non-ischemic, also non-dilated cardiomyopathy, either mildly dilated or fair ejection fraction with multiple VT. He entered a trial of ablation of such arrhythmia as his native country, and this trial was failed and even complicated by a complete heart block. So when he traveled to Egypt, he came to Egypt with such ECG. As we can see, this arrival ECG, it is a complete heart block, complete AV dissociation, and a multiple BVCs or frequent BBCs, even the BBCs have a different morphology away from the two recording tachycardia. This means there is a lot of pathology in such a patient. Our plan first to implant CRTD. Why CRTD? Because he had a fair ejection fraction. By the way, he did an MRI in his native country, which was misleading to us because it stated that his ejection fraction is about 30% with segmental wall motion and hypokinetic and scarring tissue in the infrolateral and apical segment with very low ejection fraction. So first of thing we did, we implant CRTD for two reasons. The first reason is he is in a complete heart block and his heart rate is about 35 to 50. And second, because we will do acid ablation of VT under general anesthesia. This heart rate is not compatible with general anesthesia. So first, we implant CRT successfully, as we can see, this is after CRTD. And we, after 2 days, we enter the EP lab under general anesthesia for VT ablation. We map first LV endocardial, and when we are mapping endocardial LV, multiple arrhythmia with spontaneously induced or by catheter manipulation. And as you can see, the first one, it is an odd axis. Again, it is right axis about 160 because AVR is positive and lead 3 is positive, lead 1 is negative, and again it is of apical to mid origin. Another VT was also a left superior axis minus 90. As we can see, the inferior lead is negative, and definitely it is of apical origin, as almost V2 to V6 are negative. Again, also a third one, which is like ventricular flutter, which ended by DC shock to restore his hemodynamic data. This is the endocardial endocardial map, endocardial LV map, voltage map. Of course, the VT are causing hemodynamic compromise, and we are not dealing with activation map of VT because we know that he has a different VT. So when the VT are different morphology and unmappable because of hemodynamic affection, so we will do a substrate map or voltage map. The endocardial LV voltage map was clearly of good voltage, except 2 areas only for scar. The first one is the apical, which is a small scar in the apex, and the second one is the basal septum. The basal septum at the His region, and I guess this is the reason of the complication of heart block in his native country, because I guess the operator, when did an voltage map endocardial LV, found such basal fractionation and basal scarring at the level of the head. He start to ablate in such area and causing complete heart block. So endocardial sinus map, we use a bent ray, a multi-electrode map. It's only small basal septal scar with late potential, as we can see, and a small scar from apex. Both two scars did not explain to us the lateral VT exit. We can see the LA view for the endocardium. As you can see here, the lateral wall is completely normal, and even the apical lateral is completely normal. So definitely there is an exit, either intramural exit or epicardial exit for or epicardial scar for such patient. So when we found that, we ablate the endocardial substrate, as we can see here, and by Bentaray, we could see in Bentaray 13 and Bentaray 15, there is a post systolic potential or late potential. We ablate this potential in basal septum and in the apex, and then we did an epicardial axis for epicardial also substrate mapping. Here, even without stimulation, we already know that these patients have an epicardial scar because this small scar in the endocardium did not explain the multiple morphology he had in the ECG. We did an epicardial axis by using the epidural Tuhi needle, gauge 18, this is like, and we are go from the vestibular puncture. We using also a dye to guide us, and when we are in the epicardial space, we already a long wire was passing inside the epicardium to ensure that we are in the epicardium. After we are ensuring we are in the epicardium, we insert a long sheath, either deflectable or non-deflectable long sheath. And again, we did an epicardial voltage map. When we are when we did this epicardial voltage map, definitely you can see this left lateral view. This is a huge scar inside the mid-apic lateral, mid-apical inferior segment with multiple late and lava potential. And here, when we get a post-systolic or late potential, we already we want to confirm that we are nearby the exit of tachycardia. And here is basing from Benta or from Benta 13, 15, from such a potential. And when we base here by ablation catheter, you can match the tachycardia. It is not a 12 of 12 match, but by CARTO machine, we about 96 to 95% matching of the clinical VT. As you can see, lead 1 is the same, lead 2 is the same, lead 3 is the same. So after finding that in the epicardial late potential matching the tachycardia, clinical tachycardia, this ensure ourselves that we are in the right way and we are in the right track, that we did an epicardial axis and voltage map. Also, again, from apical inferior segment, as you can see, this is the basing also from late potential in the apical inferior scar. We match the tachycardia. It's 92 to 93 match on the CARTO machine, but we are in the right track for ablation of the clinical VT. Okay, can please unmute audio. Okay, again, also there is this also a match for the clinical one from epicardial late potential. And before ablation, just to remember, before ablation in the epicardium, you should do an angiograph. We mark your ablation target, and then when you are when you mark your ablation target, you do an angiogram to see how it is the proximity of epicardial coronary artery. As we can see here in the left panel, this is the inferior apical, sorry, this is the lateral LAO, lateral scar. Also, the patient have even RVOT, lead potential, and also we use an angiogram to see away the proximity of coronary artery. And these both endocardial and epicardial, and all these ablation point in the epicardium. And after ablation, post-ablation study, no any inducible tachycardia, and this is a very good endpoint, either clinical or non-clinical. All the tachycardia had been disappeared. All the tachycardia. This rendering the VT non-inducible is a good endpoint for such a VT. Follow up 10 days in Egypt, no any recorded VT by Hill, Medtronic CRTT, and thank you.
Thank you very much, Dr. John. Amazing presentation. We have Dr. Ahmed Al-Damati, our chairperson, and Dr. Mohammed Saeed. Dr. Ahmed.
John, thank you very much for your very informative presentation. Such a nice case. I have a question for you till we get the questions from the floor. So what do you do about your anticoagulation when you decide to do an epicardial puncture after you have done already your endocardial and you must have given heparin? So can you elaborate on this point on what you do in particular? Do you reverse? Do you not reverse? Do you feel comfortable doing the puncture after giving heparin?
Yes, thank you, Dr. Ahmed, for such a very important question. Definitely, when we are going to map the LV endocardially, we give heparin. We just give 500 heparin or 700. We did the endocardial LV map in about 13 to 15 minutes.
I want to remind you, John, that you started with the epicardial axis first.
Yes.
We knew that we would need epicardial. So you started with the epicardial axis and then you went endocardial. So?
Okay. In such patient, we already did an epicardial axis. Just put a wire in the epicardium, and even without sheath, just put the long wire and do for endocardium and give heparin. But in general, in my cases, if I did an endocardium ablation and even give a 10,000 of heparin and did an map for 2 or 3 hours, I am comfortable to do an epicardial axis without reversion of heparin. Here, because most of the complication, I guess it is a liver hepatic injury or whatsoever. It is I think in the very early epicardial axis learning, I did not found any hepatic injury in recent publication. So if I give 5,000 heparin only, I am going to go epicardial without reversion. If 10,000 heparin, may I reverse with a half correction of heparin?
Already, thank you so much. Thank you.
Thank you.
Dr. John, we have a question from the floor. So afterward, did you continue on medical treatment with amiodarone as an add-on, or what was your management for the pharmacological treatment?
About the procedure, medication after medication, no, we stop amiodarone. We give an ACE inhibitor and beta blocker just for anti-failure treatment. We in such patient we did use an amiodarone because there is a very good endpoint, rendering non-inducible VT at the end of procedure is very reassuring endpoint.
Very
I
good. We have
actually have one more
Muhammad
question.
Salah.
If
Muhammad Salah, thank you. What do you think about unipolar epicardial mapping? Here, I didn't order the cartomans to make it unipolar endocardial map because this small scar did not match the clinical VT. So I'm sure there is nothing away from these two scars. So whatever the unipolar endocardial map will give me some information, but I'm definitely here in such case. I know there is an epicardial substrate. We started endocardial. Yes, definitely.
okay, great. Dr. Ashley Shin, do you have any comment before our closure?
We also have Dr. David Bradley on board.
Oh, great.
No, it's a very good case. I just wanted to ask you, when you mapped the epicardium, I know you did a nice pace map and you matched, close to the 12 out of 12 match. Did you do entrainment mapping as well, or did you just go for the exit sites?
No, we did not do an entrainment because the tachycardia was unmappable due to hemodynamic compromise. So we just depend on the late potential mapping and the perfect base match at the exit site.
Okay. It's just interesting, the etiology of the cardiomyopathy. Did you think it was sort of burnt out hypertensive heart disease as the cause, or what was it?
I think
Non-ischemic cardiomyopathy?
Non-ischemic, inflammatory, some sort of inflammatory cardiomyopathy. I was wondering with Dr. Mervat, it may be a Chagas disease, which is more present in.
Yes, we also thought of sarcoidosis, and we ordered some labs here in Egypt about sarcoidosis, but the results have not shown yet.
Okay.
So we thought about sarcoidosis, we thought about Chagas disease, because all epicardial involvement in this patient coming also from East Africa. So this is what we thought.
Okay.
Dr.
Thanks
David
very
Bradley.
much.
David.
Good afternoon, everyone. I'm sorry, Prof. I did not hear the whole case. It sounds like a very challenging one and a successful one. So I have nothing to add.
Okay, thank you.
John, I have one last question. Is it in your practice that you do NIPS a few weeks or perhaps a month after such procedures, particularly in a patient who is going to be traveling for a long distance?
Program
stimulation
stimulation
from the device.
If he came to us or he is coming to us with zero VT or VF recording, I will not do anything. I'll let him live in peace.
Yes, we sent him to the monuments in Egypt. That was our celebration with him. We have to finish now because Maghrib prayer بقى. كل سنة وانتم طيبين. Thank you.
Thank you so much.
Thank you, everybody. And until the next meeting. Thank you.
افريقيا بتلمع بس كلها مع بعض. حتى ضمات اللي بتكرههم